It says it's preparing the live stream, so hopefully we'll be online in a second. And then we'll make a start. Did you get this pop-up saying that there's a live stream?
Yes, it came up.
Good, great. All right, then I would say let's make a start. So welcome everyone. It's good to see a lot of people arriving to these events. It's been a while since we had our last event, but these seem to become more and more popular. So it's really great to see a good turnout. Some names that I recognize there, but also quite a few new faces there. So really nice to have you. Feel free, by the way, to put your cameras on and just wave to everybody. We're trying to keep these Open Digital Health events very sociable and very very interactive and open to everybody, not very formal at all. So yeah, good to have you here today. My name is Sebastian Potthoff, and I'm one of the directors of Open Digital Health. And with me today is also Dr. Ezine Onyemere, who is also part of Open Digital Health and helps organize these events, and making sure that on a monthly basis, we're trying now to bring you these. Today it's my pleasure. We have a fantastic program for you. So today we have with us Dr. Carolyn Steele-Gray. I will give you a little bit of a short bio of Carolyn, just so that you have a bit of background on her position. So Carolyn holds a Tier 2 Canada Research Chair in Implementing Digital Health Innovation. She's a scientist at the Science of Care Institute and in the Lünefeld Tannenbaum Research Institute, an assistant professor in the Institute for Health Policy, Management and Evaluation at the University of Toronto in Canada. And Carolyn's research focuses on the role of digital health in supporting integrated and person-centered care delivery for patients with complex care needs, applying implementation science and evaluation methods to uncover how to best integrate technology in novel delivery models. So Carolyn and I actually got introduced by a common friend in Spain, who is also very much interested in this field of integrated healthcare and digitalization. And I gave a talk for a master's program at Toronto University for Carolyn, so she's kind of repaying the favor. And today she will be talking about implementing digital health tools to enable integrated care. So she will do her presentation, and then afterwards there will be plenty of time to have discussions, have questions. So if you could just keep those questions until the end of the presentation, that would be great. So at this point, I would like to hand it over to Carolyn.
Well, thanks so much, Sebastian. I'm really excited to chat with everybody today. I did have an opportunity to read through a little bit about what Open Digital Health is all about and kind of your vision statement for the network. And it's, I think, very exciting, very future thinking. So I'm really happy to have the opportunity to connect with you guys and hear a little bit about you after having a chance to chat. So we'll chat a little bit about my program and what we're learning about in the space of digital health and integrated care for 20 or so minutes, but hopefully lots of questions and lots of time for a conversation. So I'll go ahead and share my screen and I guess share the very fresh news. So that was a great bio, and thank you, Sebastian. As of 5 days ago, though, I'm now an associate professor at the University of Toronto. So you would have no idea that had happened, but now I've been told make sure I update all of my stuff from the university. So that's kind of fresh news. But if anybody's had an opportunity ever to hear a Canadian give a talk, or if you've ever gone to a talk or a session in Canada, a really important part of our history and the efforts that we're making in Canada towards reparations and acknowledgement of our kind of sordid colonial history is recognizing the land on which we are working and living and understanding the history that got us to this point, which is quite challenging. And so we're working towards some reparation work. And part of that is what we do is land acknowledgements. And that represents kind of where I am sitting and where I largely do my work. So the land on which I'm presenting to you today, while it might look like I'm in a bike garage, it's traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. And it is the privilege that I have to access this land where I can go ride my bike in these beautiful places. What you can see here is an image for, close to where, from the east end of Toronto where I live, but also to the left, you can see the hospital in which I work at the Institute that views the downtown of Toronto, which is as it's more commonly referred to now. And today, this land is commonly referred to as Toronto, but is also covered by Treaty 13 with the Mississaugas of the Credit. And if you ever have a chance to hear from other Canadians, you'll hear about other wonderful nations across Canada on which we're living and working. So I want to start a little bit with where kind of Sebastian landed in my bio a bit, digital tools for a particular population. And that's kind of where the journey started, not really about technology itself, but thinking about who we're trying to serve and why. So the images you see ahead in front of you are some Canadian based data and research that points to kind of the rising prevalence of chronic disease among Canadian adults. And what you can see there to the left is an infographic from Health Canada, which is a federal agency that kind of tracks our population health needs and largely delivers funding towards provinces to deliver care. So they track our needs, and much like many countries, we're seeing a rise in chronic illness. And that presents an important challenge to our health system, which in Canada, just to level set, we have a system that's a federalist system. So we have a central government, but then healthcare is largely delivered and funded at the provincial level. So I'm in Ontario. So while we get funding from the federal government, the decisions about how that funding is run, additional funding at the provincial level, and decisions about how we set up those systems is largely up to individual provinces. So the way you would access care in Ontario is going to be a little bit different than the way you would access care in Quebec. The way we set up our integrated systems are different. The way we use our technology is really different, and leads to some really interesting fragmentation. So a lot of what I'll talk about from Canadian perspective will largely be provincial, just because it might not be as transferable. So that just level sets us a little bit for Canada. What you see in the middle, though, is a different understanding about chronic disease and why we need to think about this more broadly, that the individuals who tend to use services the most, which is actually the image you can see to your right, that's data also from Canada that looks at the prevalence of health system use by age group, but also by chronic disease population. And what you see is that group that represents the top 90% of health system of the population on the very left accounts for higher health system use that you see in the 3 bars next to you. So this is like how much of the health system utilization you're getting from this population right here. And this population, and especially as we get higher and higher, and you can see that these bars getting bigger and bigger in terms of health system use over time, and the percentiles tell you how much use we're seeing, is largely this group in the middle, which are individuals which indeed have chronic illness, but they also experience medical and physical health issues. They have social capital challenges. They have experienced mental health and addiction, and as well as kind of intersectionality and their demographic issues that make them more not seldom heard from, I guess, is a term that we tend to hear. So there are a lot of confounding factors that make the management of chronic illness particularly challenging and lead to bigger health system use. So while a small percentage of the population thinking about how to support and manage this group more effectively is kind of on our minds, not just in Canada, but internationally. So this kind of work has kind of been milling around over the last 10, 15 years as we talk about patient complexity, and has demonstrated and has shown that things like integrated and person-centered care might be a better way to serve them. We saw in that middle graphic that actually came from a colleague of ours at the Bridgepoint Hospital back 10 or so years ago, demonstrated that an individual with complex needs care from primary care, from specialist services, from home and community care, from social services. And ideally, those things are wrapping around them. And even more recently, ideally, the patient is actually part of that circle of care. So they're part of the, the decision-making group around what their care needs are. And what you see to the outside of this circle is the way that we can think about technologies as enabling and supporting this circle of care that is coordinated, collaborated, so that as multiple needs arise for this individual who's experiencing complexity, these things are understood holistically and care is delivered seamlessly, so that there isn't missed components, there aren't double testing or lost information, that ideally they're seen as an entire person, and information systems that allow us to share that data and communicate well with each other should enable this process. Now, when I talk about these types of technologies, the ones I tend to refer to are information communication technology, sort of aligned with the WHO's definition of what digital health is. I won't belabor this to this particular group, as you're all open digital health folks. So when I talk about the technologies in the space of integrated care, I'm referring to, mobile health, telehealth, health records that occur at individual organization and cross-organization levels, the health information exchanges that allow us to share data, and some increasing emerging technologies like big data and artificial intelligence. This is a newer space, I think, in integrated care, and understanding in artificial intelligence and big data is a bit newer, a little bit more in the population health management space. So I'll mostly be focusing on the types of technologies you see along the top: health records, telehealth, and mobile health, that help us in thinking about integrated care and why they can and might upend our efforts towards integration. So some of the work we've done is trying to map these technologies to what integrated care is trying to accomplish. So how do we actually support that circle of care with these types of technologies? So what you see in the middle here is Valentin's rainbow model of integrated care. And this model gives us a view of how we can think about integrated care in a useful way, that we can understand it as occurring at different levels within the care system, that you can have integration that happens at the clinical interface. So what is experienced by the patient, the person, and their community feels seamless, that they have that feeling that everyone in their circle of care is collaborative and coordinated, and there's integration at that clinical point. To support that level of clinical integration, though, you need a level of professional integration. You need those professions within units, across units, from health to social care, working together, collaborating, communicating well with each other. And that works particularly well if you can get to organizational integration, where our health systems, from primary care to hospitals to home community care and other spaces, are working more effectively together, whether they're delivering care together, they're funding care together, or ideally sharing information together, that enables these processes at the professional and clinical level. And then up finally is thinking broadly about system integration, remembering all of those needs of complex patients. That goes beyond the walls of healthcare, right? That's getting into social care, that's getting into housing, that's getting into other types of services. And ideally, when we think about integrated care, all of those components are part of how we deliver care to our patients. And ideally, if that is done well, we can get to what was originally referred to in 2013 as the triple aim outcomes, but increasingly now the quintuple aim outcomes of cost utilization, population health, experience of care for both patients and providers, and ideally health equity. So that's the aim. And if we think about this, technology can play a really important role in enabling each of these levels. Right, that at the clinical and professional level, intuitively we think, okay, well, electronic medical records, mobile chronic disease management tools, telephone and telehealth services, messaging services, all of those things allow us to share data and communicate well with our patients and communities, and really well across our professional streams if they're put in place effectively. At the organizational and system level, that's where those health information exchanges electronic health records that kind of span organizational boundaries can become really important, as well as some social network supports that actually connect broader communities between health and social care systems. So that's as we kind of move up the ladder of integration, we need to see more integration of information systems over time. And ideally, the technologies that you see supporting clinical interfaces like chronic disease management tools and clinical decision support tools, ideally those feed into these larger integration systems. So we have access to things like population health management metrics. We can start putting some algorithms on things and do preventative work. And ideally, these systems are speaking to each other. So that's kind of our ideal scenario. And we went into the literature a little bit to see how is this actually playing out in our systems by conducting a scoping review. This one just came out a couple of months ago. It was a 2-year project because our original poll of the data extracted about 40,000 abstracts around the ideas of technology, integrated care, and primary care. So we're really interested in complex patients. We're really interested in integration that included primary care because it's so central for patients with complex care needs. And so what did we find after this very large scoping review? Well, what we saw were we looked through the different types of technologies that were being used in these particular models with much larger reliance on things like smartphone apps, which is a little bit surprising. We thought we'd see a higher prevalence of health records being relied on. Lots of telemonitoring for patients with complex care needs, things like diabetes management, chronic health, CHF and COPD and other pieces, and lots of telephone. I don't know if this was similar in other countries represented today, but in Canada, when we were dealing with shutdowns around COVID, a lot of primary care moved to telehealth. We made video calls like what we're talking on today available, but largely primary care relied on telephone as their virtual care approach. And we saw that coming through in these articles as well. And we had pulled articles right up until the end of 2022, leading into this publication. So that's the types of technologies we saw, but we also were curious about the purpose, like what was technology really doing for integrated care? And what you kind of see on the left are different ways that we engage in chronic disease management. This aligns with the chronic care model from Wagner, which marries nicely onto integrated care, which you can see along the bottom. So what we see is in blue, clinical integration, green, organizational integration, as I described, red, professional, and yellow system. And on the left are the different ways that we manage chronic diseases. So what we see is lots of examples around clinical information systems that were being used, and largely those information systems were supporting professional level integration. So not so much the clinical that you might expect, kind of connecting the patient into that information, but lots around professionals communicating with each other and sharing data. Same thing with the way we set up our system, which is what's referred to in delivery system design. And notably, even in self-management, we saw much more use at the professional level than at the clinical level, which is quite interesting, right? Given that clinical integration really requires patients and providers working in that circle together. But the way things were being used was that those self-management tools were really being used at the professional level. And, much fewer examples of organizational and system level supports from our technologies, which seems intuitively what should be happening, right? That these technologies should be able to cross organizational boundaries effectively, but we were just not seeing that. A few of our best example at clinical information systems, where you have some vendors like Epic that are great at creating health information exchanges that allow us to go across systems. And quite a few of our studies kind of came from the US where we would see those examples. So this kind of led us to being a bit curious about why things were playing out like this, right? That where you have this heavy reliance on the professional level, not so much on the other spaces, and a big focus on information systems and kind of EMRs and types of stuff like that. So we applied some implementation science to understand why things were happening the way they were. And we looked at these studies and applied, and we meandered through which implementation frameworks to go through. But when you really look at some of the major ones like diffusion of innovation, normalization process theory, and things like that, they tend to focus on 4 big determinants of uptake. They tell us about the characteristics of individuals, things like e-health literacy, task coherence, stuff like that, being important to use of technology, the organizational environment, technical support, readiness for change, things like that. The external environment might be very important, policies, funding, privacy, security legislation, things like that, which will either support or upend use of technology. And then, of course, the technology itself, talking about functionality and usability. So we kind of applied these determinants, and we looked at the studies again, and we found different facilitators and barriers to the implementation of these technologies in integrated primary care. As you might expect, at the patient level, we saw digital literacy, patient attitude training, fear of losing the relationship with the provider. That's a really important one, being kind of crucial. And I'll talk about this one in a moment. At the provider level, similar findings around kind of disrupted workflow and increased workload that we might expect that would make a challenge. Maybe less expected are things like the patient-provider relationship and attitude and buy-in that are also very important. And I'm going to come back to those kind of individual level factors in a moment. And then, as I think would be expected by most of us at the technology and organizational level, really stuff about ease of use, interoperability, real technical components of this. And, what's interesting is this literature, the scoping review that was done very recently, really aligned with the case studies we had done back in 2018 of exemplary models of integrated care. So the studies looked at any models of integrated primary care. This study we did with a large international team. We looked at Ontario, Quebec, and New Zealand. We found 9 exemplary models of integrated care. And we asked, okay, how are they using their technology? Surely things might be moving further along. And notably, we saw a lot of the same pattern then that we saw in the scoping review as well, that most often technology was being used in kind of this clinical in the kind of clinical interface component. And what you see here are just fancy dots that tell us how different components of care delivery are being supported. But at the end of the day, what this really showed us was technology was most often used to support work as usual, rather than enabling new ways of working. The reason you see more types of functionality in New Zealand is they were a little bit further, they were quite a bit further along in the integration of information systems than we were in Ontario and in Quebec. So they were able to enable more of these activities. But when we dove in and asked the kinds of activities they were doing, it really looked like the way they were delivering care before they were integrated. So still lots of fragmentation and silos. So we asked again in this study, what were the implementation factors? And notably across 3 very different jurisdictions, Ontario and Quebec are very different provinces. They come at healthcare in very different ways, which I'm happy to chat about if you'd like. But very similar implementation factors here, as we saw in the data as well. And there's lots of things we can talk about here. I'm happy to talk about functionality and workflow and all of those things. But the thing that was really exciting and potentially unexpected, and we've started digging into, are things around norms and task coherence and things around culture and climate. Because these things we don't necessarily think about when we talk about technology, right? These are getting into beliefs, values, and philosophies. And often when we think about technology, we think about it to the left side of this graph. So now I'm going to bring our attention to kind of the bottom component here. What you see here are mechanisms that Valentin tells us are going to drive this integration. On the left, he talks about functional integration. That's the activities we actually do to support integrated care, the communication flows, the clinical decision support tools, the actual nitty-gritty actions that we're all doing. And we often think about technology supporting all of those things, right? There are functional uses for technology to enable the communication flows and predictive modeling and things like that we need to actually enable this process. But what we're seeing in the implementation studies that we're doing, and what we've been hearing from our sociology friends, is that technology also needs to pay attention to things like normative integration. And Valentin suggests that another really important driver of this system is shared norms, values, beliefs, and philosophies across all of these levels that actually allow people to work together. Because it's one thing to bring different organizations into a room, sit them around the table and say, we're all going to do person-centered integrated care. And it's another thing to understand, to kind of unpack if everyone even understands that concept in the same way. And if everyone even would approach it in the same way, or they value it in the same way. And those things can really stop movement forward as we're trying to put these models into place. And technology similarly is a social artifact that can influence this type of normative integration. And I really like the work of Deborah Lupton, who has talked about technology as social artifacts. And she points us to recognize that these are sociocultural products that are located within these pre-established circuits of discourse and meaning. And not only do they sit within that, but the technologies themselves are active participants that can actually shape our bodies and ourselves as part of these networks. And what we're seeing is that that's happening in technology as well. Not only are our beliefs, cultures, values shaping the technology we build, but when we put technology into place, that can actually shape the way we think about our models of care, the way professions think about their identities as professionals, the way patients think of themselves as patients. They have this interesting two-way factor happening. And so we've been trying to unpack that a little bit more in some of the studies we did. So here's a pragmatic trial we did of a technology that supports patient goal-oriented care in integrated and primary care systems. It's a very large trial. It's 10 years of work, but I'll very quickly talk about it, and I'll get to the fun stuff around meaning and values. But briefly, because you're tech folks and you talk about scaling technologies, here's a technology that became kind of shelfware, and we can talk about that in a second. But effectively, it's a mobile technology that was co-designed with patients and their providers and their caregivers to enable goal-oriented care. So that's when a patient and provider sits together. They have a conversation about their many complex care needs, and we work with patients to identify what their goals of care are. And that might not be medical. That might be, I'd like to, be able to walk my grandkids to school, or I want to make sure I get to a friend's wedding at the end of the month. And that is going to shape the way kind of care delivery is planned and what their care plans are going to be. So the mobile technology helps them set up that goal. It sets up tracking so they can see how they're doing against that goal. And then there's a dashboard for both patients and providers to see how they're doing against the goal, with the ability to kind of put textual information around why things worked or didn't, which allows for more kind of productive conversations around their care plans. So we built this over many years. We ran a pragmatic trial to assess impact on key outcomes. We did a cost analysis. And we did an embedded implementation analysis as well. Lots of papers that came out of this. I'm happy to share any or all of them. Broadly, we looked at 6 FHTs, or family health teams. Those are integrated models of primary care that we have in Ontario. It ran with 44 patients and 36 providers over an 18-month period. And then we had kind of continuous measures. And the really interesting stuff, though, comes from the embedded ethnographic case studies that we did. So in 4 of the sites, we did observations of their interactions, like we sat and in their offices as they did goal setting, as they had the conversations. And then we did multiple interviews with patients and providers over the course of the trial. And that piece becomes really interesting because it helped us unpack why things were or were not working. And we have some really interesting papers that talk about use over time and engagement over time. And we're seeing very odd patterns about some people being kind of really super users, both patients and providers, some people dropping off quickly, some people meandering in and out. So we had a lot of questions about why we were seeing very diverse use patterns that didn't seem to have alignment to other kind of traditional ways we would think. It wasn't aligned to age or digital literacy or other things like that. So we wanted to understand what was really happening. So then we applied normalization process theory I'm sure many of you are aware, this just kind of highlights the 4 components of normalization process theory. That it suggests that individuals and teams who are making sense of a new intervention have to go through a process of sense making, coherence. So, what is this thing we're working with, and does it make sense to me? They need to kind of engage with it through cognitive participation, through kind of relational work with the intervention and with each other. They have to actually do the work of operationally putting it into practice, and then they appraise it over time. They reflexively monitor, is this working for me or not? Originally, this theory suggested this was a linear pattern, though lots of research since, including from Carl May, has demonstrated this to be a more kind of circular, meandering, kind of oscillating process that people go through. And so we applied this same theory to our case study data, of which there was much. And this is a very simplified view of a very complex analytic piece of work we did that demonstrated a really interesting pattern in the way people were thinking about the technology and how that was influencing their use. That what was really important when we were working with very diverse users, so patients and providers and their care partners and caregivers, was it wasn't just enough for an individual to have coherence, for it to make sense, for them to participate in it and then to act on it, but that there had to be alignment between how the provider and the patient were thinking about the technology and also how they were thinking about what even goal-oriented care was. And it was when there was alignment between the two of them and alignment between what the technology was doing that we saw actual ongoing use, because it then connected into something that was valuable and meaningful to them. And that meant that there was a purpose to their continued use of it for both patients and providers. And in our study, you'll see that lots of really interesting quotes around, well, it makes sense to my patient and we talk about it and it makes sense to the way we do self-management. And that's why this is in use, versus those who didn't use it, where they had very disparate views of what self-management or goal-oriented care was. They may have had disparate views of what the technology was. And so what would be really interesting is we might have patient super users for a while, but if the provider wasn't kind of coming along with them for that journey, and there was that potential relational break, which we saw in some of those other implementation studies, then use kind of fell off because the meaning and value started falling away. Because this is a type of technology that just doesn't sit with one person, it sits with two. And when we talk about integrated care, we need to think about not just the one user, but how multiple users are creating kind of meaning and value around this. And so this kind of creates a really interesting challenge for us as we think about implementing our technology. And something we've been trying to unpack around what meaningfulness even is and why it's important. And in this commentary, we kind of use I use some of this study and some previous studies to try and start to unpack this idea around why meaningfulness is important. And when you look at some of the literature from philosophy and psychology, now I'm not a psychologist, so I'm super keen for psychologists to kind of come back and talk to me a little bit about this, that there are links that I was seeing in the literature between what people see as meaningful psychologically and philosophically and the behavior that they were engaging in. So if it means something, that they'll engage in it. Obviously, there are a lot of environmental factors that make that possible or not, but it is a driver we need to think about. And that can drive our technology implementation. But then if we think about the sociology literature, we know that technology implementation is going to influence meaningfulness as well. So we have this really interesting kind of relationship between these concepts that are swirling around under us just building a technology and putting it into people's hands and measuring impact on workflow. There's something else going on around the way we understand ourselves, the way we understand technology, and the way we understand our processes we need to understand and unpack. So I'm just going to wrap up with the ways that we're trying to understand this a little bit more deeply. And there are two studies kind of ongoing. One, and this paper is just submitted, was another in-depth ethnographic study where we applied social representation theory to understand how people were constructing meaning around digital technology clinical interactions in primary care and therapeutic relationships in virtual care environments, and asked whether their constructions were aligning enough for them to use virtual care meaningfully. And indeed, similar to the pragmatic trial, when we dug in deeply just from this lens, that we needed to see alignment between people's personal characteristics, their feelings about things like the technology, their past experiences, which would influence their expectations of what that technology was going to do. And that had to be aligned with their expectations of the therapeutic relationship and their expectation of the interaction. And that had to align between the patient and the provider. And in those instances, virtual care made sense. But if things didn't line up, that the way they understood technology didn't line up with the way they understood a therapeutic relationship, then they couldn't make that connection, and virtual care stop being meaningful to them as a way to actually receive good clinical care. So this is a really interesting exploratory piece of work that we're just starting down that line on. Another piece of work we're doing is more at kind of the policy space, and we've brought together patients and community providers and system leaders and other folks, a huge group of people who are trying to understand how do we actually think about things like values, beliefs in the way we put technology into practice. So we're in the process now of disentangling many deliberative dialogues we've had with this broad group to develop a series of implementation guides and tools that would allow us to attend to values, attend to meaningfulness when we put technology into practice. So that's coming up in the next couple of months. I think that's on my list this week to distill some of this. And the last thing I'm going to signal is just some work with the International Foundation for Integrated Care. And I think I brought this up mostly because of the Open Digital Health folks, that this might be a really nice place for us to intersect. So I co-lead a special interest group in this space. Part of what we're trying to do is make connections between potentially technology and people trying to solve solutions similar to what Open Digital Health is trying to do. I'm so happy to kind of chat about this and bring folks in on that journey as well. I think we're well aligned. So I think I'll wrap it there. I'll leave that there for a second. If anybody wants to reach out to me via email, please do so. But hopefully we get a bit of a chance for a chat now.
Thank you very much, Carolyn, for this fantastic presentation. I really enjoyed listening to that. And as you will see, I have changed room. My internet just stopped working at some point. But this was really amazing, Carolyn. And what I really like about your work is the different kind of theoretical perspectives that you managed to bring in and see sort of like the parallels, right? Drawing on philosophy, psychology, but also implementation and sort of how these different theories, frameworks kind of speak to each other and how you can make them useful for the kind of implementation, digital health space that you're trying to understand. So I found that really eye-opening, very, very nice work. So yeah, at this point, I think we can open it up to discussions. Any questions, comments? Please feel free to unmute yourself or raise your hand, use the chat, and we can have a discussion. Who would like to go first?
Hi, just a point of note. I think there were several people who were willing to join, but were not able to join as there wasn't the password provided because you had to register to get in.
Oh.
So the link on LinkedIn didn't do anything.
Oh no.
So quite a number of people might have missed this today, unfortunately.
I'm really sorry about that. Thanks, Peter, for letting us know. See, we're learning as we go along. So yeah, sorry about that. Well, it's great to see that still a lot of people manage to find their way here. And luckily we have a recording of today's session. So yeah, that's good to know, and we'll amend that error going forward. Do we have anybody who would like to sort of contribute? Otherwise, I have, of course, some questions for Carolyn. So yeah, I would be interested to hear your views. Sort of, you were talking about meaningfulness and sort of how there needs to be alignment between both the providers and the patients in terms of how they make sense of the intervention and kind of the meaning that they derive out of it and the value that they see in it. And I was just wondering, from the work that you've done so far, can you provide any sort of key recommendations, takeaways in terms of how we can facilitate some of that alignment and that building of relationships around technologies to facilitate integrated care?
Yeah. It's such a great question. And I think, and not just in our work, but we see this in integrated care implementation broadly, that it takes quite a bit of time, that we talk about the time it takes to build relationships. But when we see that happening, a lot of that is actually that sense-making piece, and taking the time to understand each other, but not assume that we think about the problem or the ideas even in the same way. So I mentioned kind of briefly that people in our study were coming at the notion of self-management very differently, or the notion of goal-oriented care very differently. So what we learned over time was that you can't go in and say, oh, we all want to do person-centered care. Great, off we go. Because that person and that person might have totally different definitions of what person-centered care is. So we can't assume that we understand these ideas in the same way. So taking the time to engage in sense-making early and revisit it, because sense-making is going to change over time as people work together, come up with new ideas, and engage in a new intervention, things are going to shift. So kind of consistently checking in on what makes sense to them and what it is they're trying to accomplish, and giving them the space to hear from each other so they can hear each other's perspectives can be really valuable. We see that in the governance literature and the leadership literature, lots of spaces, not just in technology. With technology, though, another really interesting thing we're seeing is that it's so part of our lives, whether you're a technophile or not, it's in the world beyond healthcare, right? And we have very big views and feelings about what technology is and isn't. And we need to attend to those very personal constructions of technology when we come to the table. A really great example, and actually I've been chatting with a colleague about potentially writing a paper about kind of the digital trauma that can happen when you put a new health information system in practice and it upends everything you do. And when you talk to a clinician who's been through a major health information system change, a lot of our hospitals are switching to Epic right now. They talk about it like a traumatic event, and they bring that with them every time you present a new technology to them, even if it's a totally different technology. I have a mobile app, you barely have to use it. It's just for your patients. But the construction of what new technology is and how it was so disruptive to who they were and what they were doing carries with them. So asking questions about your experience with digital technology, what was it like? How did you feel? What worked and what didn't? Those types of things I think are really important to prime people when we present them with something new. And the last point will be making sure we're not presenting them a solution to which they don't see a problem. Actually asking what is an actual problem that you have, and then connecting it to a potential solution becomes really important. And that allows for co-creation of what the problem even is. Helps with sense making, and it helps with aligning value and meaning of what we have to what is actually important to them at the time.
Wow, that was a very good answer, I would say.
I think about it a lot.
Yeah, I still remember the trauma I have when we had a cyber incident at our university and had to switch everything up. So I can really relate to that. Yeah, So we have some questions coming through here in the chat. The first one is from Frida. Hi, I'm really interested in the therapeutic relationships related to virtual care. What model or framework would you use to support this topic?
It's a great question. And I was excited about the study, and it's pretty new for me as well. And I think there's going to be lots of, there may be folks on the call or others who do a lot of work in therapeutic relationships that can kind of point you to different theoretical frameworks. We looked at the broader literature to unpack components of therapeutic relationships from work from the King's Fund and folks from Oxford who had been doing this in primary care. So they talked about the therapeutic relationship resting on like strong trust-based relationships, the idea of kind of co-ownership, creating safe spaces. So although my paper is in review, I am happy to like share it, just or at least sections, so I can pull out exactly the framework. So we actually kind of came at this question from a compassionate care lens, because it also therapeutic relationships aligns with what we mean by compassion and empathy. So we kind of came at it that way when we were trying to understand how people were constructing their ideas of therapeutic relationships, but we did also allow for inductively understanding what that was. So we asked them, what is an important therapeutic relationship to you? And that's where indeed the frameworks worked, but we also heard about their past experience and their expectation of relationships existing outside of a clinical interaction being important. So they would think about my relationship with my PT or my relationship with my social worker when they were thinking about their relationship with their primary care provider. Some people would even think about their relationships with their friends and family when they would talk about the relationship with their provider. So we talk a lot about, can you build a relationship via technology? And the general view is you need to meet each other first in person and then bring in the technology, right? Really interesting thing we found in our ethnographic study, and this is going to happen with a new generation of people coming in for care. Some people build relationships in technology first, and those patients wanted to meet their clinicians virtually first because that's how they build relationships. That makes sense to them. And they didn't want to be in person. They don't want to get on a phone. They want to text and they want to be virtual. And that's how they understand that's safe to them. And that's the way in. So I think we need to attend to not just like what we think a therapeutic relationship is, but how people construct that idea when we bring that forward.
Yeah, great question, Frida, and again, great response. And it just shows again when it comes to digital health, just how many different preferences there are, and that we cannot just offer it one way, but we need to give different options for people, right? So yeah, that's excellent. Thank you very much, Frida, for that. So the next question comes from Dr. Gil Horan. Thank you so much. Really thought-provoking. I'm looking at developing a digital AI model for a new built nursing home for people with advanced dementia and complex nursing needs. So all you have talked about is helpful for considering the model. I'm co-designing the model with people with dementia. I agree that meaningfulness for residents and staff is important in deciding on what tech we use to enable complex care. So I suppose just a note on how it really makes sense to people, what you were talking about. So
what I might add, Gil, because it's such an interesting space, AI in particular, and there's been lots of talk about, because AI is a bit of a new type of technology, the way we are coming at and understanding it is a bit different than we do with others, right? So I was at the American Medical Informatics Association conference this past year, and I've been doing a bit more reading in this space, even though it's not my field. I think we all have to go there because that's where we're all going. AI is interesting because it's way harder for people to understand what's going on in it. So a lot of what happens with both your patients and providers who are engaging in it is they have to deal with the black box of AI and whether they trust what the algorithm is doing. And what we see is a really interesting divergence in some of the work. I had a great student who did this through deliberative dialogues, like pre-COVID, pre-ChatGPT. She was asking these questions, which was cool. That patients and community providers were, or community residents were a little bit more trusting, but the providers and the clinicians who are trained to know exactly why they make decisions really struggled with AI because of the way we train them. They want to know exactly what information went in to do a differential diagnosis. They want to know the same thing with AI. I think there's going to be a really interesting training component as you go through this meaningfulness question. And there's some really cool work coming out, some really interesting stuff in ethics and other spaces to think through as you're putting it into your model of care. And I'm happy to make connections if you're looking.
Great. Another great question. Thank you, Gil, for that, or comment, really. But yeah, AI is very interesting, and I agree. Really depends on what you put in there, what you get out, and that's for sure.
Yeah.
Okay, so there we have one more question or comment here in the chat from our chair and director, Dominika. So thank you so much, Carolyn. Fantastic talk. I absolutely love your work. When you talk about integrated care, is this an ideal scenario that we are aiming for, or is it already a reality in Canada? Because in Australia, we discuss similar ideas, but we are still far away from reaching fully integrated care. How could we speed up the process, and do we get there sooner? I think I could say the same about the UK.
Oh my gosh. Dom, so we just came from the International Conference on Integrated Care. It was held in Belgium this year. I highly encourage, if anybody's keen, we're in Belfast next year at the end of April. It's a wonderful conference. You're going to find other people who are like, yes, integrated care is amazing. It is definitely not a pan-Canadian, pan-provincial, even like pan-Toronto reality. What Valentin presents as an ideal environment, and same thing with the UK, right, Sebastian? There are like some beautiful examples of integrated care, but we're far from scaling and spreading this at a really broad space. I think we have like pockets of innovation that are doing well. And as a community, I think we're moving away from talking about integrated care to integrating care, that we are never going to quite reach that point, but that we actually need to think about it like a practice, that we're always engaged in integration in some way, shape, or form. And what that allows us to do is think about the diverse and changing needs of our communities and regions, that allow us to be adaptive in the way we set up our model, because the way we set it up now might not be what we need in 5 years. So that allows us to think more about not just, attaining a particular model, but attaining a process that allows us to create a sense of seamlessness for patients, that it can adapt to their needs over time. And that can be things like governance structures, funding models, information integration, which would be really nice. So like setting up the foundations for that, and then setting up processes to allow feedback loops. Another really cool set of literature is around learning health systems, which is really aligned with what we think about in integrated care, but attends to not just the integration of services, but how we continuously learn and adapt to our environment. We have some really neat examples here, but the folks that I know who are really leading in the space, when they look around, they say, there's maybe like 3 actual examples of learning health systems that we see globally. So it's a challenge. I think to get there sooner, and how we speed up the process, is by taking the time first to set up the sense making and the relationship piece, and then establishing processes to move forward. We have some really interesting stuff happening in Ontario around what's called Ontario Health Teams. Certainly not a fast process, but faster than previously. So some top-down drivers with some bottom-up allowance for adaptation seems to be a way to move forward more effectively. But I think jury's out on whether it's going to happen fast or not.
And I think one of the things that we need to consider is also like, how fast do we really want to go, right? Like from what you were saying, is like you don't want to like jump new systems onto people all the time, right? It should be a slow, kind of deliberate, well, not slow, but a deliberate process that actually takes into account like the different perspectives, and to develop kind of clear and consistent communication, so that meaningfulness and value is really established, and we're not just sort of forcing change just for the sake of change, right?
Yes, which leads you to different problems, which Quebec is a very interesting example, right? They're very top down, and they just kind of barrel forward. They get to a good place, but you can get to like a lot of burnout and other challenges when you do it that way. I agree, Sebastian. You can go faster if you're intentional, right? Because then you're not trying to boil the ocean. You're not trying to like integrate everything for the sake of integrating. You're like, well, what are we actually trying to solve? Let's make some sense of this and iterate forward, and you can be more effective that way.
Yeah, I mean, that speaks a lot to some of the implementation work that we've been doing here, and also using normalization process theory, where we sort of did a lot of ethnographic work, observations and interviews of teams actually doing implementation, where we've given them some tools. And I think what we saw is, in order for them to go fast, they first need to go slow. that they actually need to kind of put their existing process under a microscope and actually slow things down in order to kind of understand what are their existing routines and the kind of action pattern, you could say, to make any adjustments. And you need to give them some time to do this kind of deliberation and allow for some of that reflexivity to make changes. I think it's an important point.
Yeah.
We have another comment here from Philippa. So she really enjoyed your presentation as well. And she says, you mentioned perspectives about the use of digital health tools by organizations according to experiences. What are the main challenges and obstacles for organizations to implement digital health tools focused on integrated care, and how could we facilitate this process? So I guess on an organizational level.
Yeah. Philip, such a great question. I was just in a chat with some of my senior leaders this past week because I've been very frustrated with these processes. And the thing that has been a bit of a blind spot for me until maybe the last 6 months when we started doing those deliberative dialogues and I've started having more conversations with senior leaders in the organization is the process of procurement, privacy and security, and the general risk aversion that our healthcare organizations experience, which make it really difficult to put new information systems in. So particularly in Ontario and in Canada, a lot of our legislation rests on the way we thought about technology like 10, 15 years ago. And it doesn't follow along with the way how quickly technology is advancing in terms of being safe and secure and the way it even operates. So we end up going through these very long privacy assessments, these very long procurement processes that rest on old ways that technology functions. And the bureaucracies of our organizations and the systems that regulate our health system organizations are so slow, they can't keep pace. So I think, what we're talking about more now, and I haven't seen examples of anybody doing this really quickly and effectively, but what we're trying is having more preemptive conversations where everyone is actually around the table versus guessing at what everybody wants. Particularly when you're getting into procurement and privacy. So if you have, one group of lawyers from your organization, assuming a vendor is trying to do something nefarious, actually, if you bring them in and have a collaborative conversation, you're probably going to get aligned a little bit more quickly. The other people who have been pretty successful is when they bring like their privacy ombudsmen and any legislator of privacy and security into conversations very, very quickly. And finally, it's the people who are doing it well have a culture of learning and adaptation. So we have some really interesting hospitals that are very tech forward, but at the end of the day, it's a leader who's willing to kind of push and find the margins of the regulation environment that allows them to try something new and be innovative and bring their organization along. So kind of like dynamic leaders understanding the system, these things can kind of help us move, and then continuously kind of lobbying those who hold the reins on what we can and can't do, to understand the environment that we're trying to actually work in so that we can be better aligned, is what I've seen working. But again, not a ton of examples of people who've like really knocked it out of the park. If other people may have seen it, and I would love to hear about that.
Yeah, great. We're slowly running out of time. So if anybody needs to rush off, that's absolutely no problem. Put an evaluation link in here as well. So if you could take 2 minutes to give some feedback, that would be highly appreciated. We already know about the password issue, so thanks for bringing that to our attention. We didn't have this problem before. But if you have a couple more minutes to stick around, maybe Carolyn, you can answer the last question here that's coming through, if that's okay, by Dave, because we don't want to let anybody hang here. So thanks, Carolyn. Really appreciate the concept of aligning on goals and ideals in addition to technology. How can emerging and innovative vendors get involved in helping to further collaboration and prove some of their own conceptual ideas?
That's a great question,
Excellent
Dave.
question, yeah.
it's so good. And I think, you know, and this, I guess, is my own soapbox. I believe deeply in collaboration and understanding each other. So building really strong relationships with vendors when I work with them has been really effective. And again, not assuming what a vendor wants versus what a healthcare organization or a provider want before you come to that conversation, like coming in early and being not necessarily as a vendor presenting, here's my solution and off you go, but coming in as a vendor and saying like, what's really important to you? And then allowing for some ability to adapt what you have to what the need is, can build trust, understanding, probably build a better product that will actually like be implementable and people want to use because it aligns to a problem that they're trying to solve. So I think as much as you can be collaborative and adaptive as a vendor working with teams, I've seen be very effective. And those are the vendors I like to work with the most because we don't have in-house development. So we always work with vendors. When I look for people who I want in my team, they're aligned with what we're trying to do for patients and communities. Like we have the same vision and we're willing to adjust and adapt to each other's needs in order to get there. And I think that builds a lot of trust on both sides so that we can kind of move forward.
It rounds it up really nicely. I think it's about adaptability and finally alignment, isn't it?
Yeah.
Staying adaptable, but then also finding alignment to move forward. Yeah. So thank you everyone for coming along today to today's Open Digital Health event. Thank you very much, Carolyn, for presenting. Clearly, it was very fascinating to everyone. I'm sure if you have further questions, Carolyn would be happy to be in touch, right?
Yeah,
we will make the recording available as well for anybody who couldn't attend today. Yeah, and if you have a couple of minutes spare to answer our questionnaire or survey, our what's it called, evaluation survey, that would be very much appreciated as well. So thank you everyone, and keep an eye out for any future events.
Right. Thanks so much for having me. Appreciate it.
Thank you, Carolyn.
Thank you.
And I will follow up with you, Carolyn, also regarding the national leaders.
Yes, that's going to be super fun. I look forward to that. Okay.
Great. Amazing. So bye, everyone.
Bye-bye.
Bye. Thank you.
Bye. Zini, can you just stick around for 1 second?
Yeah, I'm here.
Hi, Peter. Thank you for letting us know. That's
all right.
That sometimes happens if you work with a team of volunteers. We all do it in our free time.
I understand.
Errors slip in. But yeah, and also I would give like an open Zoom link, but nowadays Zoom, it always asks you to have some level of security. So yeah. I think you need that password, but yeah, in the future we will always make sure to include it, of course. And nice that you managed to come along.
Yeah, I just had to get here. I had to register as a member for the
ODH,
organization, and then I could get the correct link.
Yeah.
So,
okay. You found the workaround.
Exactly. I also posted the YouTube link to this live recording on the LinkedIn page. So you have
Peter, if you want to become a team member, let me know. We're always looking to recruit people. You seem to be on top of that with the technology.
Sure. You have my details.
Yeah. I mean, no, seriously, if you're interested, we do always look for people in our engagement team, and we're always like kind of looking to up our game when it comes to these events. I don't know if this is the first one that you've been a part of, the first event, or have you attended past events as well?
This is the first one I've attended. I had LinkedIn with another one before, but I hadn't had the time to attend. So this is the first one I attend.
Okay, yeah, but if this digital health sphere is of interest to you, and you're looking for something like this, we have a really fantastic team of people that we work with. I can send you like a meeting invite, and maybe we have a chat about it and see if it's something you'd be interested in getting involved with.
Definitely.
Amazing. Well, thank you very much, Peter, for helping out today.
No problem. Have a nice day as well. And
yeah, good to see you.
Likewise.
Yeah, bye-bye.
Bye-bye.
Thank you, Peter. Bye.
You're welcome, doctor.
Welcome, doctor. This is what how they talk to me usually. I met one of the students actually at London's King's Cross, and they came to me and they were like, "Hello, Dr. Sebastian," and I was like, "Okay, what a coincidence!" Where I met the students.
Okay. Oh, but today was really nice and the turnout was great.
Yes,
Had about
yes.
23 people.
It was really great. You could see like people could have continued asking questions. I mean, Carolyn
Yes,
is
it's lots
also
of time.
Carolyn is really great. Like she's somebody who just,
Yes,
you can tell that she enjoys like the research that she's
she
doing.
enjoys and she has great understanding of what she's doing.
Yeah, so I'm trying to like create more collaboration with her. We had like an initial meeting because there's lots of overlap in the implementation work that I do and
Okay.
that she's interested in, also in the theories and so on that we use. But yeah, no, it worked really well. I think, of course, the Twitter thing or like the LinkedIn thing, that's a bit of a faux pas, but I mean, it happens. I saw it actually as well, and I was like, but because I never need the password to get on here because I'm the event organizer, I didn't
You're
think
the
much of it.
organizer, so I think
I didn't think much of it, but yeah, just need. I think it was Lenka probably who like scheduled the advert. So I'll let her know that we always need to make sure to include the password. But luckily we have the